Four forms. Do we mean the etiologic cause of aortic stenosis congenital, like bypass the aortic valve, rheumatic aortic stenosis, calcific, or valve in valve? Or the risk category of the patients. We have a prohibitive risk category, we have the high risk, we have the intermediate risk, and we have the low risk. Or based on the age. We have children with aortic stenosis that required intervention, we have young adults, we have old, and we have the elderly. All these are different forms of aortic stenosis. And as we all know that TAVI was developed as an alternative to aortic valve replacement in the very or extremely high-risk patients population, and its first implantation in men was performed by Crepier in 2002. Since then, there has been a non-stop development of less invasive strategies with lower mortality, lower morbidity, and less invasiveness. Its indications are expanding to include intermediate risk patients and potentially low-risk patients in the future. And we have to not to forget the surgical approach. We have the conventional aortic valve replacement, median sternotomy, and this made the surgical intervention not popular and not accepted by the patients. And recently we have the minimally invasive surgical approach. Minimal invasive surgery aims to minimize the degree of surgical intrusiveness. Currently, there are several surgical approaches. The most frequently is a partial sternotomy and the right anterior mini thoracotomy. As regard TAVI, definitely we have the bright side of the TAVI and we have the dark side. I will look at the bright side first. The bright side is that with outstanding clinical trial results, TAVI has been rapidly implemented across the globe. And we have a lot of trials, starting with Partner 1 in patients with prohibitive surgical risk, then Partner 2 in patients with high risk and intermediate risk, and lately we have the Partner 3 in patients with low risk. All of these trials have a very good results with TAVI as compared to surgery, and even TAVI was superior to surgery in such trials and in the last trial with low-risk patients. And again, we have an active trials. Currently, there is significant clinical investment in applying TAVR to young patients at low surgical risk, both in North America and in Europe. And this is the penetration of TAVI. If we compare 2015 to 2025, we are expecting that TAVI will increase by fourfold. This is a penetration of TAVI worldwide. And again, we have this iterative device design. This iterative device have been designed to mitigate complications, simplify the procedure, Dr. Thomas said, and improve upon current anatomic exclusion to enable the treatment of more patients. And we have more and more refinement and development of this device. We'll have the Ovolute Pro, CBN 3 Ultra, and Lotus Edge. What is the dark side of the TAVI? Actually, the complications we're afraid of. We're afraid of death of the patient, myocardial infarction, stroke, vascular complications, which minimized a lot after the introduction of the closure device and refinement of the devices, bleeding, acute kidney injury, prosthetic valve performance, stenosis or regurgitation, and paravalvular leak. If it's moderate or severe, it carries a poor outcome, thrombosed endocarditis, and we have a prosthetic valve associated complications like conduction disturbance and need for pacemaker, coronary obstruction, mitral valve affection, aortic root perforation and rupture or dissection. And we'll stress on coronary obstruction, aortic root perforation or rupture that may lead to death of the patient on table. And these are the measurements necessary for that. I will not go through all of this, but I will again to stress on the sinus dimensions, on the height of the coronary ostium above the valve, and basal septal hypertrophy, what we call a suicidal left ventricle in patients with severe left ventricular hypertrophy. All of this should be taken into consideration, and these are the measurements that should be taken in every case as a pre-procedural. Why we take all of these measurements? Because some patients will not be suitable for TAVI, like those with a short distance between the insertion of the aortic valve and the coronary sinus, and some patients with shallow aortic sinus, because the incidence of occlusion of the coronary arteries in these conditions are very high. And this is the general incidence of coronary obstruction that can lead to death of patient on table. It's very rare actually, it's 1%. Signs and symptoms may be subtle and not appreciated until after the procedure, and most cases can be avoided by good pre-procedural preparation using CT, that some patients will be referred to surgery because of this complication. And this is a coronary obstruction. Mainly the cause of this coronary obstruction is the height of coronary ostea and dimensions of the sinus of Valsalva. If the height is low and the narrow sinus of Valsalva, this will be associated with a higher incidence of coronary obstruction that will be catastrophic on table. Again, if we are talking about all forms, regarding the etiology, rheumatic aortic stenosis is excluded from randomized controlled trials, and we don't have evidence to use TAVI in such patients. About bicuspid aortic valve, as Dr. Thomas mentioned, that bicuspid aortic valve are often associated with larger annulus dimensions, an asymmetric valve orifice, heavy eccentric calcification that is a cause of rupture of the annulus, a dilated and asymmetric aortic root and ascending aorta. These anatomic variations definitely will lead to poor outcome, and complications that may arise in this condition is significant paravalvular leak. Again, this is associated with poor outcome, non-uniform, non-circular valve deployment, device migration, embolization, and embolization of the valve inside the ventricle is a fatal condition, and annular rupture, which is also a fatal condition. What about valve-in-valve TAVI? Well, there is a short-term evidence to show that valve-in-valve TAVI is as good as redo surgery. Long-term results are not available. But the current challenges with valve-in-valve TAVI include elevated post-procedural gradients, patient prosthetic mismatch, coronary obstruction, malpositioning, valve-in-valve durability is questionable, a higher rate of leaflet thrombosis. And again, if we are talking about coronary artery occlusion, the incidence of coronary artery obstruction in patients treated by valve-in-valve is 3.5%. This is a higher rate of coronary obstruction that will increase the mortality of such patients. Again, if we are talking about all forms, we're talking about the risk category. Definitely prohibitive risk category and high risk, these are indications for TAVI, and I'm going to talk about this with low risk. Low risk means that STS score is less than 4 with no frailty, no comorbidity, and no procedural specific impotence. And low risk young patients means 40 to 60 years. Three important aspects should be taken into consideration when we deal with such patients. The TAVI procedures are not without or free of major complications like coronary obstruction and rupture of the annulus, especially in some forms of aortic stenosis like those with bicuspid aortic valve and valve-in-valve. We have to ask about the durability. Until now, we don't have the long-term durability of such procedure, and a very important part, especially in low-income countries or developing countries, the cost effectiveness of this procedure. In addition to the lack of evidence to support TAVI in low-risk patients, major concern for young patients, including the durability and the replaceability of the aortic valves. Very important questions to be asked. Number one, do we have the ideal valve till now? We have a lot of valves, but do we have an ideal valve? Do we have a single valve that fits all forms of aortic stenosis? No. We have valve that is superior to other valves in some forms of aortic stenosis. That's why we don't have a single valve that match all forms of aortic stenosis. Do we have a single operator who have experience in all types of valves? Definitely. We don't have this single operator. And these are the main contraindications to TAVI. We have an absolute contraindication to TAVI, especially patients with inadequate annulus size and those with elevated risk of coronary ostium obstruction. And we have some relative contraindication, especially those with bicuspid aortic valve. So, in conclusion, TAVI is not yet ready for all comers with severe aortic stenosis. Nonetheless, it is on the way to becoming the major player in treating most, not all, patients with severe aortic stenosis. And a paradigm shift away from the current surgical risk-based model to novel models in younger patients is needed, and there will continue to be a few anatomical limitations that will still require open heart surgery. From the economic point of view, it's clear that for high-risk operable patients, TAVI is currently a more expensive therapy and probably a less effective alternative to surgical aortic valve replacement with an incremental cost-effectiveness ratio that may be acceptable for high-income countries, but definitely not for moderate or low-income countries. Moreover, the medical cost of TAVI therapy needs to be reduced to make this technology economically feasible for hospitals and global health care. However, the current practice guidelines give good pathway for choose the adequate therapeutic option in each individual case. And this is a guidelines recommendation. Definitely, it is class 1 recommendation for TAVI in prohibitive and high-risk patients. And it is class 1 recommendation for surgical aortic valve replacement in low and intermediate risk patients. TAVI is a treatment of choice in all forms of aortic stenosis? Definitely no. It could be a reality, hope, or dream. In the meantime, TAVI shouldn't be the treatment of choice in all forms of aortic stenosis. Thank you for attention.